Thank you, Art, and thank you, Luciano, and thank all of you for being here. I'm going to try to tell you two sides of a myth and try to tie together some of the things we've already heard from the brilliant two talks that preceded mine. I'm going to tell you a positive side, and I'm going to tell you a negative side, and try to show you how they can be brought together. First of all, when we say, let's open the lung, what do we mean? We cannot open all of the lung. We all know this. But a fully open lung is one in which all non-consolidated alveoli are aerated, have air in them. No recruitable alveoli remain closed during both parts of the tidal cycle, and therefore tidal opening and closure is eliminated. This is the idea and the definition of an open lung. For me, the awareness of this became evident when I reviewed this editorial before it was published by Lachman, who said, let's open up the lung and keep it open. I think he was motivated in part by the study by Webb and Tierney that suggested that when we start with a rat lung and use positive end expiratory pressure, keeping the lung open protected the lung, possibly because of surfactant depletion not occurring. Did keeping an open lung and not depleting surfactant prevent ventilator-induced lung injury? That was the theory at the time. Burkhard Lachman, one of the smartest people I've ever met, worked predominantly in the laboratory about clinical issues, and he was influenced by many pediatric considerations in which the depletion of surfactant or the inactivity of surfactant is of critical importance. The rationale developed and the proposed benefits for the open lung were, let's increase the membrane surface for gas exchange. Let's renew surfactant and protect it. Let's prevent atelectrauma, the damage that we've just been hearing about. Improve the uniformity of driving pressures throughout the lung. And reduce the levels of infection in the lung itself and then in the bloodstream. And studies have shown that over the years, all of these have relevance. I'll quickly just mention a few. This study by Suarez-Sitman and colleagues looked both at Deadspace and at Shunt and showed, of course, that as the PEEP increases, going from right to left, both the Deadspace and the Shunt improve. So increasing PEEP and opening the lung seems beneficial for gas exchange in this model. And notice that Deadspace did not deteriorate. It was a progressively opening lung model. So the emphasis became, at that point, not on overstretching the lung or creating amplified forces of stress focusing at the junctions, junctional stress and shear, but in opening and closure prevention. This was the historical background. Higher PEEP may indeed reduce the gradient of pleural and transpulmonary driving pressures. PEEP is good for that, in that sense. It has consequences, as I'll tell you later. So there became a surfactant central hypothesis. In other words, absolutely critical to preserve surfactant. Surfactant depletion accentuates collapse and stress focusing and ventilator-induced lung injury. Surfactant generation requires aeration. Repetitive cycles of opening and collapse deplete and degrade surfactant. And sustained opening of lung units, therefore, is key to lung protection. Open lungs allow surfactant renewal and repair of the degraded surfactant that we know exists in the setting of acute lung injury and ARDS. From Bjorn Janssen, we have this nice illustration of how closed lungs encourage terminal airway damage and depletion of surfactant as it is propelled into the terminal airways and also degrades from large forms to small forms inside the lung, making the lung more collapsible. I think this is still important. As Giacomo suggested, actually, maybe not knowing it, but suggested it, PEEP may be important for that reason, to protect against deterioration through surfactant mechanisms. And I'll say more about that as I proceed. Rick Albert, one very intelligent and an excellent investigator in Denver, put forward this surfactant-centric rationale for keeping an open lung, where he suggested that, in fact, we start with an injured lung, but we make it into ARDS because we ignore surfactant. And I don't want to go through the mechanism. He did a nice job in explaining it and the scientific rationale. It's worth reading. This surfactant central hypothesis and our emphasis on opening and closure being so important and keeping an open lung has problems. In America, we say there's a fly in the ointment. There's a problem to be considered. Why is the fully open lung an ARDS myth? First of all, the ARDS lung cannot be fully recruited. Even the recruitable units can't be fully recruited. The rationale for its objective is defective. The ARDS etiology, its severity, and most importantly, the stage and severity affect its relevance. Another thing is small tidal volumes and low driving pressures reduce the risk attached to tidal opening and collapse. I think Luciano was referring to that in his questions. When we use small tidal volumes, maybe opening and closure loses its potential importance. I'll talk more about the latter two. The required airway pressures have bad consequences, and strategies with this objective have shown no consistent benefit. We know the high-frequency oscillation story. Don't forget that we also have evidence that exogenous surfactant, no matter how often it's been tried, has not worked in established ARDS. That's extremely important to remember. The stage and severity in established ARDS does not work. Patients differ with respect to how much lung is recruitable. This is an argument that we've already brought up this afternoon. And some of this recruitability we're looking at is, in fact, fluid transfers and redistribution. Some of this opening and closure we talk about is actually fluid redistribution, as Rolf Hubmeier and colleagues have shown. So therefore, because of a diverse population studied at different times with different techniques and severities, we get different percentages of the lung, of ARDS, which are said to be recruitable. Fully developed ARDS may be much, and a little bit later in the staging, may be much closer to what Luciano showed than what Matos and the Brazilian group showed. They suggested that much of the lung is openable. They were studying earlier patients with flooded lungs. This is important to realize. In our laboratory, Paolo Pelosi, working with me and Luciano, published this paper long ago. I reference it a lot because it showed us so much. You can take an experimental animal and increase airway pressure and make the lung almost totally lucent. Experimentally, full recruitment may be possible, but it takes very high pressures. And in a companion paper, Crotty, Luciano, and colleagues, including me, demonstrated that when we open the lung, we need very high pressures to open some lung units, and other lung units collapse, most of them at a fairly low pressure, but others at a very unsustainably high pressure. Some lung units cannot be opened by any reasonable level of PEEP. Are some lung units always opening and closing? Maybe, in the pressures that we commonly use, but a small percentage of them. as we've just heard. A small percentage, not as large as shown here, a smaller percentage. Okay, the rationale for keeping fully open lung may be defective. The ARDS etiology, severity, and stage affect its relevance. The small tidal volume and low driving pressures reduce the risk to tidal opening and collapse. We go from a very sensible, realistic strategy in the lab, in babies, to one that does not make sense for patients with ARDS. And the required airway pressures have bad consequences. The early emphasis on atelectrauma, when you have a lot of collapsed alveoli, is not prudent when you have a different lung that has much less recruitability. Unyielding lung units then become susceptible to overstretching and the junctional stress and repair that are the atelectrauma that we've just been hearing about. It is the stage and severity that are important. Didier Dreyfus, one of the great contributors in our field, wrote this very nice commentary, should the lung be rested or recruited? The Charybdis and Scylla of ventilator management. Should we veer too close to the rocks or too close to the whirlpool? We need to navigate through the center. And I think he was right. The required airway pressures have diminishing returns as we increase airway pressures on hemodynamics, stress amplification, dead space, and the power delivered to the lung. Strategies with this objective have no consistent benefit. If we look at APRV, if we look at high-frequency oscillation, and I've already talked about exogenous surfactant, they don't work. It's not that they don't work any better than a standard lung protective strategy. The consequences of an open lung strategy on hemodynamics, gas exchange, stress amplification for unopened units, and raised mechanical power is what I'll discuss very briefly next. Remember, every time we open the lung, we distend it, and lung expansion may increase vascular stresses. In Zone 3 conditions, alveoli may be quite well perfused. In Zone 2 conditions, dead space increases if there's no compensatory recruitment. I showed you earlier a model in which recruitment predominated. But in many of our ARDS patients, when you don't have a lot of recruitment, then increasing the PEEP level in the pursuit of the fully open lung may cause Zone 2 conditions throughout much of it, causing dead space and vascular stresses. And of course, right ventricular strain, Veillard-Baron and colleagues have shown maybe 25% of our ARDS patients have excessive strain on the right ventricle and on other cardiac structures. Art would probably say something about this study, the Oscillate trial. It was well designed, but it used very high levels of PEEP to open the lung and keep the lung open. It used very low tidal volumes. Two things that should have protected the surfactant protection aspect of VILI avoidance, but in fact, problems developed. The driving pressures were low. Everything should have been right. But maybe these consequences for hemodynamics were important. Did Oscillate sail too close to the danger zones of the fully open lung? Well, Didier Dreyfus again wrote this nice commentary suggesting that it did. The pressures were simply too high and caused ventilator-induced lung injury on the high side of overstretching. And I wrote a piece that discussed these things too. Now, if we look at what kind of strains injure the lung, a normal lung, they have to be in the 2 to 3 range. And Luciano's done so much of this work and explained it so well. I'll just say that the lung is really indifferent to the pressure range, the open lung, through much of its course. But once you exceed a threshold, then you're in for problems. And when we look at the stress and strain definitions, remember that this concept of using PEEP plus multiplied by compliance plus tidal volume divided by FRC is the strain that results from the pressure that we apply. PEEP is in there. PEEP helps determine global strain. Inside the heterogeneous lung, stress focusing amplifies the effect of increased global stresses that PEEP causes and increases the driving power that we deliver to the lung. If we follow the dictates of the mathematical methods, it appears that this is a very powerful multiplier, so that anytime we increase the applied pressure, any unopened units are being subjected to tremendous forces. And this could be far from a protective effect, it could be a dangerous effect. Look at it this way. If you're using a driving pressure in a low PEEP range, and you increase PEEP, there are fewer units that are subjected to stress focusing. But as the PEEP goes up and you cross a threshold, some lung units become excessively strained. PEEP adds to the global strain on unrecruited tissues, and most of the tissues we have are unrecruited. It's been shown before in this symposium that there is a threshold for injury, whether we're talking about pressure or power. Experimental injury thresholds are high and they're distinct, very sharp, whether it be rats, dogs, pigs, and presumably human beings. Anytime you raise the PEEP above a certain level of mean airway pressure, you are subjecting certain stress-amplified units to dangerous tensions. Lastly, we talk about energy now, and this is all due to the work of Luciano and colleagues, and I don't take any credit for it, but here is how the pressure and volume relationship is depicted. If we look just at the non-resistive profile, and we look at the dynamic components, and we look at the PEEP components, PEEP potentially energizes the cycle by quite a lot. You deliver much more energy per cycle. And when you multiply that by frequency, you get the delivered power that could be injuring the lung. So raising PEEP has a consequence. And here, for example, 20 hours at 45 milliliters per kilogram tidal volume devastated a lung that was perfectly fine with 52 hours at still a very high tidal volume in work that Luciano's done. Okay, finally, I want to remind you people, coming from the land of a very moderate man, that we need to consider moderation in all things, okay? I think we learned that well in France this past month, thank God. Okay, going back to 1975, Peter Suter. Does everybody not know this slide? This is total compliance, and you can read it as driving pressure because he used constant tidal volume. Tidal volume divided by compliance is driving pressure. There was a peak value that coincided with best oxygen delivery and with least dead space. So, in conclusion, I would have to say that it is a myth that we should fully open the lung, and there are dangers associated with it. When does it make sense? It's not for established severe ARDS, especially when low driving pressures are used. Maybe for patients at risk, very early, with minimal disease or atelectasis and high ventilation requirements. Yes, for babies and experimental animals. But open lungs now, when you make the shift from early and mild to severe and late, makes no sense. Grazie.